For spending your evening with us. All right, so it's 7:01. I'm just going to go ahead and here and get started. For those of you who don't already know me, my name is Leah. I'm the director here at eMedical Prep, and I will be the host here this evening. Who you're seeing on your screen right now is Dr. Deepak Puri, and he's a real world-renowned cardiothoracic surgeon, and he is our featured guest speaker tonight, and we're so honored here to have him. Um, just a little bit about eMedical Prep. If you're not familiar, we're a fully online allied healthcare training program. A lot of our students, most of them are actually pre-med and pre-PA students looking to learn clinical skills to gain those direct patient care hours that you might need for your medical school applications or your PA school applications. So we get you trained, we get you certified, and then we get you placed into a paid position with our career services. There's also externship placement as well if you are interested in that. You can complete the program in as little as 8 weeks, but you have 1 full year to complete the program as well. At the end of our session, I will put in the chat a discount code for all of our attendees for half off of our enrollment into our CCMA program. So stay tuned for that. And yeah, thank you for joining us. And this is our monthly clinical shadowing webinar series. So each month we have a new featured speaker, whether it's a physician, a surgeon, a physician's associate, a nurse practitioner, come and share all of their knowledge and their education, their skills with us. Sometimes they will present a patient case. Sometimes they will share with us their expertise in exactly what they do. So at the end of this, you all will receive a certificate for 1 hour of clinical shadowing for spending your time with us. So without further ado, I want to introduce Dr. Deepak Puri. We're so happy that he is here. Like I said, world-renowned cardiothoracic surgeon. He has so much to share, so much to offer. I actually got the honor of meeting Dr. Puri over the summertime at the University of Pittsburgh Medical Center while he was there teaching or learning about robotic heart transplantation. So that was very interesting. So we formed a really great relationship. And so I'm just so happy that he was able to come and talk with us. So I'm going to just turn it over to Dr. Puri.
Good evening, everyone. And thank you, Leah, for giving me this opportunity to share my experience with the participants.
So happy you're here. Thank you for coming.
My pleasure. You want me to share my presentation?
Absolutely. Yeah, let's just go ahead here and get started. We want to know everything you know. Tell us everything.
So, I'm Dr. Deepak Puri. I'm the chairman of cardiovascular and thoracic surgery at Paras Health in India. So Paras Health is a chain of 8 hospitals across 5 states in India, and our vision is to deliver comprehensive management of all multi-specialty and super specialty treatment to the patients, and we want to deliver it in a cost-effective manner. And we are rapidly expanding, and more hospitals are coming in the future years. And apart from giving the best clinical management to the patients, we promote an integrated approach in which the clinician come together as a team, and we deliver not only the interventions, but we also believe in starting right from the primordial prevention to the primary prevention, and then early management, and later on management of complications and interventions, rehabilitation, and secondary and tertiary prevention. So I will briefly tell you about myself. I did my schooling from St. Edward, Shimla, which is the summer capital of India in the British regime. and it is a very beautiful town in the Himalayas. And then I did my medical graduation from IGMC Shimla, which is a very highly rated medical college in the north of India. And then for my post graduation and my super specialization, I went to PGI MER Chandigarh, which is the topmost institute delivering super specialty trainings to the residents. And Graduates from PGI, they are working across the globe, and they are in top positions. Later on, I shifted to Fortis Hospital, which is the leading hospital chain with more than 80 hospitals in India. And this was the first Fortis hospital, and I joined the hospital and worked there for 13 years. I was the additional director of cardiovascular and thoracic surgery. And later I moved to Max Hospital, which is also a chain of multi-specialty hospitals in India, and I was the senior director of cardiovascular and thoracic surgery. In between, I was looking after seven hospitals of IV healthcare, which is now called Livasa, and I was the executive director and head of the cardiovascular sciences there. And I joined Paras 6 months back, and now I'm chairman, and I'm looking after the eight hospitals of Paras Healthcare in India. So I had the opportunity to visit US multiple times, and I got the opportunity to be in the University of Maryland in Baltimore. That was almost 15 years ago. And Dr. Jonas Bonatti, who was the president of robotic surgery, he was the head of the unit. And I worked there in robotic and advanced coronary interventions. And there I met Dr. Eric, who went on to become the director of Swedish Hospital Seattle in USA. And I had the opportunity to be there also with him and see the minimal invasive approaches and the robotic surgery program. And then after that, we started a global trust called Cardiomersion, which is basically the main aim is to find out new innovations that would help in delivering the best healthcare and to integrate it. And then we educate the people, clinicians, as well as the community across the globe to get the best out of the healthcare. And also, we want to take care of the community right from the early age, going across the primordial prevention, primary prevention, early diagnosis, then the guideline directed medical management, interventions, the optimum and the risk-free delivery of intervention in time, and which are also cost effective. And then we continue the rehabilitation as well as secondary prevention. And we want to educate everyone to take care of your heart and also your mind and remain healthy, fit, and young forever. And I also had the opportunity to visit Leipzig Heart Center, which is one of the biggest heart centers in Europe, and every day performing more than 30 cardiovascular surgeries. And later on, I also went to VATS International Workshop in Shanghai, and there they are doing a lot of thoracic surgery, the highest number of thoracic surgeries in the world, every day performing around 150 surgeries with uniportal VATS. And we had started doing uniportal VATS now more than 10 years ago, and we are done a lot of complex cases also. I'll share a few cases with you. And recently, when I met Leah, I was in Pittsburgh. In the University of Pittsburgh, I had the opportunity to participate in the lung and heart transplant program, as well as the robotic surgery program. And it was a highly informative, and there was a lot of learning experience, as well as we shared our own experience with them. and we want to continue exchanging the clinical knowledge as well as spread the awareness about the innovative new techniques that would help in delivering the best healthcare to the people across the globe. So today I'm with you, and I want to make you aware that cardiovascular diseases, they are the number one cause of death nowadays. In the recent survey, it was found that 20.5 million deaths occur every year because of cardiovascular disease, which is almost 33%, one third of the total deaths. And more than 75% of these deaths occur in lower and middle income countries. And also it is seen that the number of deaths, they are almost double that of the deaths caused because of cancer. And it is seen that many patients who have cancer, they actually do not die because of cardiovascular disease, but they die because of heart disease. And there is a close correlation between heart disease and cancers and other lifestyle diseases. The risk factors are common, which is like some are modifiable, some are not modifiable. So the non-modifiable are the hereditary, the racial, and as the advancing age, the cardiovascular risk keeps on increasing. And Asians and Indians, they are highest at risk. And also, we see that those patients who are smoking tobacco or they are abusing alcohol and who have a faulty lifestyle, they don't do any activities, they have a sedentary lifestyle and who eat junk food and take a lot of cold drinks. And apart from that, they have high cholesterol levels, they have obesity, and they have high blood pressure also. So these patients are more liable to get heart disease, and the mortality in Asian and Indian population is increasing every decade. And I think in US they have been able to achieve better prevention, and the awareness is also quite good. That's why they have been able to control the mortality in the last decade. However, the mortality among female population is still on the rise. There are multiple factors because the females, the heart disease goes unrecognized, and most of the people they have a myth that females have less heart disease, but actually more than 50,000 more females die because of heart disease compared to men every year in US. And now there is a special like subject which is dealing about the heart disease in women. And there are many specialist cardiologists also who are specializing in heart disease among women. Most of the women, they don't have typical symptoms, and that's why heart disease is sometimes missed. And most of the times, half of the women, they are diagnosed only when they first get their heart attack. So there are other various problems there that are seen in delivering the cardiovascular care. And especially in India, we see that the disease is affecting the younger population, more young population. They are suddenly having cardiac arrest and dying, and they don't even sometimes get a chance to get medical attention. And also, there are a lot of myths being promoted about the management of cardiovascular diseases. Because of that, the patients they don't come forward for the treatment unless they get the complications. And then there's non-evidence-based promotion of unconventional methods and injudicious promotion of complicated technologies, in which we don't have clinical evidence that they are actually as good as the normal conventional methods that we are already aware of. And then the doctor-patient relationship is deteriorating fast. And there's a lot of emphasis on cost cutting And because of that, there may be some quality cutting also. And also, we are not getting adequately skilled professionals, and because the new technologies are coming, so there is an industry-driven campaign to introduce these technologies without actually adequately training the healthcare professionals. And there is growing stress and deteriorating working conditions among medical professionals throughout the globe, and much more in India. And also, I would like to share with you that right from birth, we start weaving the web of risk factors around us. And most of the people think that the risk factors, they affect us when we go into the middle age or as we become old. But actually, it starts from the childhood. And the most common risk factors are tobacco use and alcohol abuse and high cholesterol levels, high blood pressure, faulty dietary habits, physical inactivity, and obesity. And many studies have shown that if a person gets cardiovascular disease, then most of them they are either smokers or they have a faulty lifestyle, they are having obesity or diabetes. And same is the case with cancer. And also, when the patient becomes diabetic, they become more prone to have not only cardiovascular diseases, they are more prone to cancers also. So there's a close relationship between all these lifestyle diseases. And um, like the spider weaves a web and then gets trapped in the web itself. Similarly, we are weaving the web of risk factors around us, and then we get trapped in this web. And also, it is seen that those who have cardiovascular diseases, they may later develop cancer, and those who have cancer, they may develop cardiovascular diseases. So now, even a new subject has come, which is known as cardio-oncology, which deals with the management of patients with the close interaction between the cardiovascular diseases and the cancers. So, one thing which I want to emphasize to all the youngsters is that when we are using our left brain for the right-handed person, we are using it for all the knowledge and all the analytic things that we do and all the skills that we acquire. And at the same time, we are ignoring the passions, and also we are ignoring the creative activity. And because of that, the balance between our lifestyle and our profession is not going fine. And that's why most of the healthcare professionals themselves, they are more prone to lifestyle diseases, and then they are also more at risk compared to the general population to have heart disease and other diseases like cancers and obesity, diabetes. So we have to take care of our own lifestyle also to become a good healthcare professional. So I will share a short video with you which shows that what is the life of a cardiac surgeon and how they encounter so many surprises every day, and they are round the clock on their toes. So in this video, this is a cardiothoracic team going to perform a surgery on a heart surgery on a patient, and suddenly they find out in the operation theater that there's a scar on the chest, and the patient has not revealed any history of any previous procedure. And on the OT, when they detect the scar, then they ask the resident to go out and find out that why the scar is there. And then they find out that the patient had previously undergone surgery for a thymic mediastinal tumor, and also the patient had undergone radiotherapy also. So because of that, there were adhesions of the aorta with the chest wall, but because the surgeon was not aware, so when he was trying to open the chest, then you can see what disaster occurred. So accidentally, when he was cutting open the sternum, the aorta which was stuck to the sternum um, opened and ruptured, and here you can see suddenly as the heart was pumping the blood, entire blood was spilling over and the patient's blood pressure was collapsing, and the surgical team was like in a problem. They were trying to stop the blood flow. The blood pressure dropped to less than 40 systolic. And in this situation, and the only option is that we put the patient on a cardiopulmonary bypass machine. And for that, we have to do the cannulation in the femoral artery and femoral vein. And then we divert the blood from the femoral vein to the cardiopulmonary bypass machine. And then the heart stops and the cardiopulmonary machine takes over. And then we do the surgery. And after the surgery, then we again, once the surgery is performed, the aorta is repaired, then we stop the cardiopulmonary bypass machine and reactivate the heart. So s- surgery is like a battlefield for the cardiac team, and every time there are surprises going on. So we have to have the stress level is very high, but we have to learn how to cope with the stress and how to manage the patient efficiently. And uh, within few minutes, we have to take control. So sometimes this is a rather funny video which you can see, and then you find out some the all other problems associated with the surgical team, especially the personal relationships uh, and the relationship with your spouse, relationship with the patient. Can you hear the sound of the video?
We can't hear, I cannot hear the sound of the video. No,
You can't hear?
no, we can't hear it. If
So
you,
here the surgeon is starting a surgery, and his wife is the nurse assistant, and she's asking for a divorce at the time of the surgery because the surgeon is always busy. He doesn't have time to interact with the wife.
so we can't hear the video.
So they are having a hot discussion while the patient is waiting for the surgery. The patient is also having stress. So that is also a very dangerous situation that because of the busy schedule, you're not able to devote time for your family. And ultimately, the relationships are also getting affected, and constantly the cardiac professionals, they are under a lot of stress. And because of that, they are more prone to cardiovascular disease themselves also. And then we have seen with the impact of COVID pandemic, we have seen that there is a 29.9% increase in the fatal heart attacks between the age group of 25 to 44 years, which is very glaring compared to the increase of 19% in the 45 to 64 years age group. So, why the youngsters are getting sudden deaths is that because of the COVID pandemic, there is an increased tendency of clot formation. There is an increased tendency of heart failure and stroke and the arrhythmias. And it is seen that those patients who had a mild form of COVID did not require hospitalization, their risk increased 10 times. And those who needed intensive care hospitalization, their increase risk was more than 100%, 100 times. So why the youngsters they are more prone to sudden death is that they don't have collateral circulations developed. So when the artery gets blocked because of a thrombus, and then there is a sudden blockage of heart blood supply, and the heart can go into cardiac arrest. While in the elderly population, they may be having some collateral circulation when the blockage has been going on slowly over a number of years and decades. Then the collateral supply is able to maintain a minimum amount of blood supply during the heart attack so that the muscle remains viable and does not get infarcted quickly. So this risk is more prone among the younger age group compared to the elderly age group.
Dr.
So
Puri, this
yes,
is Leah. I'm sorry. I just have a quick question. Can we go back to that slide for just a moment?
yes,
I just want to make sure that I understand this and that all of our students understand too. Um, so the younger population who has had some type of form of COVID-19, they have an increased risk of studying cardiac death because they're young. And the older population has had time, if they've had the older population has some form of blockage in one of their arteries, that they have had time to form other blood supply flow to the heart, and over time, where the younger population hasn't had that time to form or to grow that um, other, that
collateral
blood,
circulation.
yeah, that circulation, okay, to the heart. So that is why that is the younger population has a higher risk of sudden death from COVID-19. Okay, thank you so much for that
Thank you.
clarifying.
Thank you. So another problem that we are facing nowadays is the increasing burden of heart failure. So the most common cause of heart failure in India is that after a heart attack, after myocardial infarction, the patient they come late to the hospital. So once the heart muscle gets infarcted, then even if we are able to salvage the patient will remain a heart failure patient for the rest of the life. So almost 50-60% of the patients with heart failure in India, they are because of late presentation to the hospital after the onset of the myocardial infarction. And this burden is increasing day by day, and this is becoming a silent epidemic. And it is seen that uh, their mortality in the long term is also very high. We have a almost 30% mortality in the first year, and 45% in 3 years, and almost 60% in 5 years. So if you compare with the Western population also, the figures say that the patients with heart failure, almost 50% of the patients may die within 5 years if they are not getting proper treatment done. And also it is seen that the Indian population, the mean age of having heart failure, that is almost 20 years less than the Western population. So more younger Indians, they are getting heart failure, and also the number of re-hospital admissions is also high. And also it is seen that most of the patients, they don't become aware that they are having heart failure unless they have a very much onset of symptoms like a shortness of breath. When they come to the hospital, suddenly it is found that they are having heart failure. And also, it is seen that this failure may be precipitated by acute coronary event, and later on, by proper treatment, then the patients usually they recover. But the normal course of progress is that they have sudden exacerbations as well as improvements as the time progresses, and later on, like the heart failure, it is having different stages. In stage A, uh, there is a risk of heart failure, but there is no structural heart disease. In stage B, there's the onset of structural heart disease, but there are no sign and symptoms. And in stage C, there's a structural heart disease and there are sign and symptoms, and the patients they are undergoing some treatment, and gradually it progresses and it becomes a refractory stage D, in which the patient needs interventions. So if you talk about the medical management of heart failure, we have four pillars of management, and guideline-directed medical therapy has improved the outcome of heart failure in the last decade. And in this, now we have class one indicators like ARNI, which is sacubital valsartan, and then we have beta blockers, then we have MRA, and then we have SGLT2 inhibitors. So all these form the four pillars of heart failure, and if we start the treatment in time, then most of the patients they progress to an extent that even the biggest trial, the Syntax trial, has shown that even if the patient who are having multivessel disease, if they are put on proper guideline directed medical therapy, then the outcome is quite good. And recently, we also have one new drug which is the cyclic GMP activator, and it increases the nitric oxide pathway. And through that, the patient with the rapidly deteriorating or acutely decompensating heart failure, they are getting benefited, and this drug is known as Variciguat. And then another problem that the heart failure patients they face is that their renal function also starts deteriorating, and these patients are more prone to get hyperkalemic episodes. And it is seen that they are re-hospitalized frequently for these hyperkalemic episodes, and gradually the interval between two admissions becomes shorter and shorter, and ultimately the patient lands up with a mortality. So we have to take care of this also. So when we talk about the signs and symptoms of coronary artery disease, everybody thinks that chest pain, shortness of breath, and palpitation, they are the common symptoms that the patient may get. But many patients, they don't get any symptom at all, or they may be getting some symptoms and they ignore the symptoms, or they are not aware that this could be because of a heart attack. So if the patient has got cold sweats, if the patient gets jaw pain, back pain, or any discomfort above the level of the umbilicus, so we must keep in mind heart disease. And also, especially in diabetic patient, there may not be any symptoms. The patient may present to us when they have like a severe LV dysfunction, they can present with extreme fatigue, or they may present with shortness of breath. And sometimes the patient, the first presentation is that with a heart attack, and many patients they miss the heart attacks and they think that it may be because of other cause, especially in women. Sometimes people think that it may be because of some hormonal disorders. They have vague complaints like weakness and tiredness and sometimes headaches. So sometimes the diagnosis may be missed. So when we do the screening for the coronary artery disease, the most common pathway is that we do an ECG, and one must know that ECG may not show anything, but that does not rule out that patient may be having a coronary artery disease. So next step is that we do the stress test. So in the stress test, the most common is the treadmill test, and if the patient is not able to walk the treadmill, then we may advise a dobutamine stress test, or we may do some thallium stress thallium, for the patient, or we can do like for screening, we can do a multi-slice CT angio and see the calcium score. And if the calcium score is high, we may see whether there is some blockages going on in the arteries. And the most commonly performed test is the coronary angiography, which is the gold standard for seeing the specific sites and the severity of the narrowing. And after that, we decide what treatment should be given to the patient. So if the patient gets a heart attack, then this is a dire emergency. And if the patient doesn't get proper treatment, sometimes the patient may go into cardiogenic shock when the systolic blood pressure falls below 80 millimeter of mercury, and then patient may even have a cardiac arrest. So we say that time is muscle, muscle is time. Each minute of delay can decrease survival chances, and also the muscle may get infarcted permanently, and the patient may become a heart failure patient. So we have to act quickly. So whenever there is a suspicion of a heart attack, we must inform the ambulance, and the treatment starts from your door. So once the ambulance is there, patient is shifted, patient should not do any activity. And then we do the loading. If the aspirin is available, the loading is done at home only. And also we can take some nitrates like sorbitrate and place it below the tongue. The patient should not move about, should be immobilized, and we quickly transfer. The treatment starts from the door of the patient, and the ambulance takes the patient to the hospital. The cath lab is ready. So if the patient has a ST elevation MI, then we have to quickly shift to the cath lab, and we have to do a primary PTCA, or we do the percutaneous intervention to open up the artery. And this is known as the door to balloon time, which should be in very good setups. It should be less than 30 minutes, but definitely it should not be more than 1 hour. So if the patient is staying at a place where cardiac facility is not immediately available, then if it is taking more than an hour to shift the patient to a cardiac facility, then first we should thrombolyze the patient and stabilize the patient before shifting, because many times if this shift the patient, if the patient has to travel a long time, then the patient may collapse on the way and may die. So we have to know a few things, that the difference between heart attack and cardiac arrest. So cardiac arrest, the heart stops actually beating. So it may be because of a heart attack, or it may be because of some conduction problem, electrical activity of the heart stops. And then we have to immediately revive the patient, because we have to start CPR immediately. We have to call for help. And if we don't do that, within 3 to 5 minutes, the brain will become dead, and we will not be able to salvage the patient. Even if we do the CPR and if we revive the heart, the brain will not recover after 5 minutes. So time is very crucial, and we everybody must know how to do a CPR and how to revive a patient. So I will show you an ECG. This ECG, this is the ST segment, and if the ST segment shows an upward elevation, so this is a ST elevation, myocardial infarction. So if there is no ST elevation, this is known as non-ST elevation MI, and there may be some depression also, and T wave inversion also. So we do first ECG. If it is normal, that does not rule out a heart attack. We have to keep the patient under observation and do serial ECGs, and we send the troponin test. So troponin I starts rising within few hours, and will keep on rising for the next maybe 24 hours or more, and then it plateaus and then starts coming down. So if the ECG is normal, and if the troponin is normal, but still if the angina pain is persisting, then we call it as the unstable angina. So according to the severity, the ST elevation MI needs prompt revascularization. And if there's a non-ST elevation MI, then we have to optimize the patient, and then we have to see when we can do a coronary angiogram and then treat the patient accordingly. And for unstable angina also, we have to stabilize the patient, and then the urgency is not as much as we have in the ST elevation MI. So also we have to understand, if a patient has suddenly fallen unconscious, then we have to see whether the patient is having a heart attack or whether the patient has had a cardiac arrest. And sometimes the patient may be having a stroke, whether it is a hemorrhagic stroke or it is a thromboembolic stroke. So we have to rule out what is the possibility. And also, we have to understand that the heart has a coronary circulation, and it has got a um, electrical circulation, that is the conduction system starting from the SA node to the AV node, and then the bundle of his and the Purkinje fibers. So most of the people, they have a confusion whether this is a blockages in the arteries or in the conduction system. So everybody must understand that, like, I give an example that at home we have the water supply and we have the electrical supply. So both of them, they are interdependent. Like the water is used to run the turbines and which generates the electricity. And when there is no electricity, we are not able to pump the water into the um, pipes. So they are interdependent. So if there is no electricity, there will be no water, and if there is no water, there may be no electricity. So similarly, in the heart also, sometimes when the blood supply to the muscles stops, then at the same time, the blood supply to the conduction system may also be affected, and it can cause arrhythmias, which may be fatal, or it may result in a total cardiac arrest also. So I will share one episode when I was returning after organizing a Cardiomergen conference in Tokyo. So one passenger, he boarded the plane and had a breakfast, and then after that he was having discomfort in the upper part of the abdomen and chest. So he contacted the air hostess and she gave him antacids, thinking that it may be because of the indigestion. Then the patient, again, after half an hour, he said that he was not comfortable, and again, he was given another antacid. So after that, the patient became more sick, and then there was an announcement that if there is any doctor on board, then you must come and examine a patient. So I rushed, and I found that the patient was collapsing, and we made him lie down on the floor of the aircraft, and I called for him. There was no response. Then I checked his pulse. There was no pulse, and there was no breathing. So I shouted that this is a cardiac arrest, and we have to do a CPR. And I started the CPR. And then we told them that, see, this patient is having a cardiac arrest and we need to land somewhere. He needs cardiac attention. So they told that we are on sea, and there is no land nearby. It will take 3 hours to go to China, which is the nearest land. And I told them I'm not sure if we take to China whether we will be able to get immediate attention. So can we take somewhere in India? Because I am from India, maybe I may be able to get him quick medical attention. So then they said that Calcutta is the nearest. So it was 5 hours away, more than 5 hours away. So we continued the resuscitation. We took all the permissions from the ground staff, and we diverted the flight to Calcutta. And there, the ambulance was ready. The patient was immediately shifted to a nearby cardiac center, and on angiography, there was a complete occlusion of the left anterior descending artery. And then it was opened up, and after that, the patient was stable, and we were able to salvage the patient. So after that, like there was a lot of hype in the media across the globe and from different countries. This news spread all over. Then I searched the net and I found that every year almost 1,000 people they die in the flights. And most of the people they are not aware because the protocol is that if a person dies, then he is made to sit in the chair and the seat belt is fastened, and it is not announced that person is died, so that the passengers they don't panic. And then the entire all those on board they are once they leave the plane, then after that this patient is shifted. So many times there were incidences when the co-pilot had died, and the pilot thought that maybe he's asleep. So many times there may be a medical emergency, and the team may not be able to cope up with that. Although it is mandatory for the flights to carry all the necessary equipment with them. And the team is also trained to do the cardiac resuscitation. But still, when the actual situation arises, then there may be panic. I got a phone call from cardiologist. There were four cardiologists who were traveling to a flight from UK, and then they were traveling for a conference, and the patient had a cardiac arrest, but they were not able to salvage because in a cardiac center, like we have all the team and all the facilities available, but if the thing happens on a flight or if it happens somewhere in public place where there is no facility, then sometimes it is very difficult to revive a patient. But still, if we make an attempt, then we may be lucky to revive the person. And everybody must know how to do the CPR, and everybody must be having some ACLS and BLS training so that you may be able to save a life anywhere. And also, like if you have, if the time permits, I can show you a video in which there is a situation. So can you hear the audios?
Dr. Pure, I was not hearing the audio when you play, when you share your screen, there should be a box to check that says share audio.
Okay, if you can't hear the audio, I'll just tell you what's going on. So this is a situation when a person gets a cardiac arrest. So we have to shout for help, and we have to follow the doctor's ABC.
ABC is airway, breathing, and circulation.
If there is no response, if there's no heartbeat, if there's no breathing, then we have to shout for help, and then we have to inform the ambulance immediately, and then we have to start the CPR. So we have to compress in the middle of the chest with our palm as shown, and then we have to continue at least 100 compressions in a minute. If you are alone, then after 30 compressions, you have to give two breaths. So we have to maintain the circulation to the brain and to other vital organs till we get help. And we have to continue uninterrupted, because if we interrupt, the circulation to the brain and the vital organs will stop. If the AED is available, then we can just attach it, and the AED will detect whether this is a shockable rhythm or not a shockable rhythm. If it is a shockable rhythm, then it itself gives a shock to the patient. So if the patient is having arrhythmia, the heart will be reverted and the patient can be salvaged. So if we can do this in time, then we may be able to save a life. So when we deal about the management of cardiovascular emergencies, like I give the example, like in the armed forces, we have the army, we have the air force, and we have the navy. Similarly, for the management of cardiac patients, we have the army, which is the surgery, the normal open surgical techniques that we follow, that we go to the place of combat and then we do what is required and then we come back. The other thing is the Air Force, in which we go through the video scopes and we do a videoscopic or like total endoscopic, that is known as TCAV, which may be a robotic procedure. And then we have the Navy, in which we go through the bloodstream and then we put a guide wire and then we see what is to be done, and we may inflate a balloon, or we may put a stent, or this is done for other problems also apart from heart attacks, which I'll subsequently show you some slides and videos, and you will come to be aware about that. So there has been a lot of progress in cardiac surgery, which started in 1950s, and it is almost 75 years now, and there has been rapid progress. And at the same time, the percutaneous intervention started much later, and there has been a lot of improvement in the percutaneous techniques also, and they are closely competing with the improvement in the cardiac surgery. And not only the interventions are improving, the diagnostic techniques are also improving day by day. Yet, when we come to the main question that when there is a heart attack, then which is best, whether we should go for a percutaneous intervention or we should go for a bypass surgery. So, there are multiple like options. If there is a single vessel and we have a culprit vessel, then in acute situation, just a percutaneous intervention of the culprit vessel, angioplasty is the treatment of choice. But if we have multiple artery blockages going on, then most of the guidelines they say that if there is multiple artery blockages, and if the patient is a diabetic patient, and if the patient is having a decrease in the left ventricular ejection fraction, that is, the patient is having ischemic heart failure also, then the treatment of choice is CABG. The American Heart Association and the European guidelines, they all have uh, revalidated that, even in the latest guideline, they say that CABG is the first choice of revascularization strategy in the patient with multivessel disease and acceptable risk to improve the prognosis, and also if there is a left ventricular dysfunction, and especially in the patient who are diabetic patients. And also, it is emphasized that the medical and the surgical options are not competitors, but we have to use them judiciously, and they are complementary to each other. So, um, when we go for a surgery, at the same time, we have to optimize the patient medically also, especially if the patient is having heart failure. Then we have to see to it that the failure part is also taken care of, and we have to give the best treatment. And nowadays we go with the heart team approach, and the heart team, the cardiologist, the cardiac surgeon, and the cardiac anesthetist, and the patient's relatives, we sit together and we decide that which is the best option to the patient. And then we can go for a bypass surgery, and then we can even go for a hybrid procedure, like in which the it is seen that the left anterior, the left internal mammary artery to the left anterior descending artery anastomosis, it gives the best long-term results. So if we can do a Limma to LED bypass, and we can do it by a minimal invasive approach, and in Maryland they were doing by the hybrid procedure, in which they did robotically the left internal mammary artery to the left anterior descending artery. and then rest of the arteries they were opened up by percutaneous intervention. So this is the hybrid approach. So many times if the patient is having a mitral regurgitation and patient is very high risk for surgery, then we may open up the culprit artery by percutaneous approach. The mitral regurgitation decreases, and then we can go for the surgical bypass. So whatever be the course of action, like later on, we have to keep the patient on a lifelong follow-up. We can also do regular screening, and if there is some native vessel progression, or maybe there's some progression going on in the graft, then we can do a percutaneous intervention, and the patient has to be given a normal lifespan and a healthy lifespan. So initially, the bypass surgeries were being done by putting the patient on a cardiopulmonary bypass machine. And even still, in most of the parts of the world, they still do the bypass surgery by putting the patient on a cardiopulmonary bypass machine in which the circulation is diverted to the heart lung machine. And we stop the heart, do the surgery, and after that, we again restart the heart and take the patient off the bypass machine. So the first time the by heart surgery was performed, it was before the invention of the heart lung machine. The surgeon thought that for doing the surgery there was a congenital defect in a baby, and he thought that if the uh, child circulation can be supported during pregnancy by the woman's bloodstream, so why can't we do it after birth also? So what he did was that he diverted the circulation of the child to the father of the child, and during the surgery, and after that, once the surgery was over, then it was again diverted back to the child, and they were able to perform the surgery. But later on, after the heart lung machine was invented, all the surgeries they are being done by putting the patient on the heart lung machine. But then we also have a intra-aortic balloon pump in which, like if the patient is having cardiogenic shock, or sometimes if there are very tight blockages, and if the patient is on verge of collapse, so we might help the heart by inserting an intra-aortic balloon pump into the descending aorta, and this uh, expands and contracts, and it augments the blood pumping, and helps the heart by decreasing the afterload during systole, and by increasing the augmentation during diastole. So now we also have the Impala device, which is inserted into the left ventricle, and it helps the left ventricle in pumping the blood more efficiently. So this can be kept for a longer time. The intra-aortic balloon pump is usually taken out within a week, but Impala device can be kept for much more, many weeks also. So here in the late early onset of the millennium, we saw that more people they got interested in doing the surgery on beating heart. So if we want to do a surgery on a beating heart, then we have to use the octopus stabilizer to stabilize that part of the artery which is being bypassed. And initially, we used to put these block the artery proximally and then open up. But during the anastomosis, the blood supply to the part of the area of the muscles was disrupted, and then it sometimes used to worsen the function of the heart, and sometimes the patient used to collapse, especially when we were doing lifting the heart to do the lateral anastomosis or the posterior anastomosis. So then the patient had to be put on emergency bypass machine in an emergency, and the morbidity and mortality rate was higher by doing this procedure and beating heart. So many surgeons they were not able to overcome the learning curve, and sometimes they used to do like they used to leave some bypass grafts and do incomplete revascularization. So then a lot of studies they were showing that the long-term outcome may not be as good as the surgery performed on pump. But when we were doing the surgeries in these patients, so we require a few devices also. Like these are the various stabilizing devices, which is known as octopus, and this is the chest retractor on which the octopus is placed, and we have the intracoronary shunts. So once we open up the artery to do the anastomosis, this intracoronary shunt is a hollow shunt, so that whatever blood supply is flowing, it should continue to flow while we are doing the anastomosis, and also there will be no outflow of blood at the level of the anastomosis when the shunt is inside. So the visibility will be better, and then we have to place the patient in the Trendelenburg position to maintain the blood flow and maintain the hemodynamics. And we have to, the anesthetist has to be very active, and we have to see that when we lift the heart, the blood pressure doesn't drop. And by doing all these maneuvers, we were able to gradually do more and more off pump surgery. So we started doing off pump surgery in 2000, and by the time we reached 2004, we were doing all the surgeries on beating heart. So there was another more important issue that those patients who have ischemic heart failure and those who have a low ejection fraction, the outcome of surgery was not good when we do the surgery by diverting to the cardiopulmonary bypass machine. So cardiopulmonary bypass machine itself was a risk for doing such surgeries, and the mortality rate was much higher. So once we started doing these surgeries on beating heart, the outcome was much better. So we were able to do very complicated surgeries in patient with low ejection fraction as low as 15% or 20% with moderate MR. So we were able to do the surgeries on beating heart. So these patients had a quick recovery in the post-operative period and used to go home within 4 or 5 days after the surgery. But those patients who used to be done on pump, they it was difficulty to wean them off the pump. The heart used to swell up, and also they had more renal complication, more arrhythmias, and they were sometimes stuck in the ICU. So even the guidelines also, AHA guideline also says that if there's a acute MI or if there's a ischemic heart failure, then the if the surgery is performed out the off pump, then the outcome may be much better. But if the surgery has to be performed in an emergency situation on off pump, then the person has to be skilled in doing that. So if unless you are able to do the normal surgery off pump, then suddenly you can't do a complicated surgery off pump. So there was a lot of debate, and I think by 2010, most of the literature they were questioning whether the off-pump surgeries actually should be done or should not be done. So I will share my experience with you that during this period we were doing all the surgeries off pump, and after 2004 we never used to put the patient on cardiopulmonary bypass machine. So I was invited to the Asian Biennial Conference, and my topic there was is of pump surgery a passing fad. So the irony was that I was to give this talk in front of the people whose books we had read during our super specialization MCS training. So the chairperson, one of them was Dr. Brian Buxton from Australia. So his book on surgery for coronary artery disease, we used to read that book, and also we had Alan Carpentier, whose chapters we used to read in our books, and they were against beating heart surgery. They were in favor of on pump surgery. So I was to speak in favor. So after that talk, I'll show you a brief video that there was a long discussion during the tea break. People did not leave for the tea break. So I'll just tell you briefly that there was a long discussion, and they ultimately told me that we showed the videos of what kind of surgery we had done. So they said that you people have taken off pump surgery to a level beyond our imagination. So it was very heartening for us, and we continue to do the off pump surgery. And today, it is almost 15 years now after that discussion in the Asian conference. And I'm proud to say that we are still doing the surgeries on beating heart. And now everybody recognizes that India is number one in beating heart surgery. I'm
Yep,
just sharing our information. Like we have a counseling scan form for lifestyle assessment, and we have like a scan for the YouTube channel we have. So we keep on posting videos on the YouTube channel, and some may be for the medical professionals, some may be for the community. And if anybody wants to contact us, this is our mobile number, and we have websites also, and you can contact on the WhatsApp also. So if we can help you in any way, we'll be very happy. And whenever we organize the global conferences, we will be happy to have your participation also. And everybody is welcome to join our YouTube channel, and you can subscribe it, and you can enjoy the videos.
all right. Well, thank you so much, Dr. Puri. Thank you so much, everybody, for joining.